Okay, welcome everyone to BostonSight's Practitioner Education Series. My name is Laura Castle, and I am the Director of Professional Affairs and Consultation with BostonSight. BostonSight is a nonprofit healthcare organization that advances the treatment of diseased and damaged corneas and dry eye. Our ongoing commitment to research and achieving optimal patient outcomes through innovative scleral lens design, education, and technology have saved the sights of thousands of people around the world. Tonight, we are very excited to have Dr. Gloria Chiu and Dr. Stephanie Pisano here to present Reducing Lens Suction, How SmartChannels Can Improve Fit, Wear Time, and Long-Term Ocular Health. During the next hour, they will discuss how the addition of BostonSight's patented SmartChannel, the only design feature of its kind in the market, has become such a versatile tool in their scleral lens fitting. Dr. Gloria Chiu is an Associate Professor of Clinical Ophthalmology at USC Roski Eye Institute, Department of Ophthalmology at the University of Southern California, Keck School of Medicine. She received her Doctor of Optometry and completed a residency in cornea and contact lenses at the Southern California College of Optometry, where she still serves as an adjunct faculty member. Her clinical interests include contact lens fittings and treatment for patients with ocular surface disease and irregular corneas. Her research interests include microbial contamination in contact lens-related solutions and effects of scleral lens wear on the ocular surface and optic nerve. She is a fellow of the American Academy of Optometry and the Scleral Lens Education Society, and a member of the California Optometric Association. She was named one of America's Best Eye Doctors in 2021 by Newsweek and GP Practitioner of the Year by the Gas Permeable Lens Institute in 2023. Dr. Stephanie Pisano is an Associate Clinical Professor, Optometry Division at the Ohio State University College of Medicine. Dr. Pisano practices in the Advanced Specialty Contact Lens Clinic in the Department of Ophthalmology and Visual Sciences, where she sees patients in need of specialty medical contact lenses for various conditions. The Advanced Specialty Contact Lens Clinic uses the highest level of scleral and contact lens technology to evaluate patients in need of custom contact lenses. These technologies include eye print impression, PROS, and polarimetry. She is a member of the Ohio Optometric Association, the American Optometric Association, and a fellow both the American Academy of Optometry and Scleral Lens Society. There will be time at the end of tonight's presentation to answer questions. Dr. Chiu and Dr. Pisano do have a lot of great content tonight to share. So if we run long and we do not get to all of your questions, we will be following up with an email along with a link to tonight's webinar. So Dr. Chiu and Dr. Pisano, welcome, and thank you for being with us tonight.
Thank you so much for your kind introduction. It is really an honor and pleasure for Dr. Pisano and I to be here this evening with BostonSight, as well as all of you who are joining us after a possibly very hectic and long day in clinic and with your patients, maybe even as you were fitting some scleral lenses. So our topic for tonight is reducing lens suction. We're going to be focusing on how BostonSight SmartChannels can help to improve fit, wear time, and long-term ocular health. Dr. Pisano and I both work in academic medical centers closely with our cornea colleagues in ophthalmology. So we've seen lots of things, mild cases, moderate, train wrecks, and we're hoping that we can share some clinical pearls with how we've utilized these smart channels to help benefit our patients. So let me move forward here. So whether we know it or not, we've all experienced suction to some degree in our scleral lens wearing patients. Whether we've experienced it while trying to remove a lens of our patient in office, or maybe we've heard about challenges that our patients have experienced themselves. As we all know, when you go to remove your scleral lens, if you apply that plunger in the center, it creates a suction effect and makes it very difficult for the lens to remove. However, if you apply the plunger to the edge of the scleral lens, kind of break that fit, the lens will come out with much more ease without that suction that feels like sometimes patients have reported they feel like they're pulling their eye out. We definitely don't want to see that. But let's just try to understand what's happening with suction in scleral lens wear. Well, Dr. Karen Carrasquillo published in 2020 in Contact Lens Spectrum kind of a description of what's happening. And she writes that suction can occur when micro quantities of fluid are essentially squeezed out of that fluid reservoir as the lens lags during horizontal ductions and movement, and when it's compressed during blinking. So essentially, if the volume of that fluid reservoir is not fully replaced when the eye turns to its primary position and straight ahead, and during this decompression or relaxation between blinks, this negative hydrostatic pressure builds up and causes that suction or difficulty removing the lens or possibly other challenges moving forward. Some signs and symptoms of suction in scleral lens wear include, in acute stages, limbal chemosis or swelling. You can also sometimes see microcystic epithelial edema. So it's almost like this light haze on the outer part of the cornea, just like this rippling orange peel-like effect. You can also see, not only swelling, edema, chemosis, and also rebound hyperemia. So this redness that maybe you don't appreciate it when the lens is on the eye, but upon removal, you suddenly get a gushing of blood through the vessels, and you see this redness on the conjunctiva. In chronic cases, you may see peripheral neovascularization. And with symptoms, patients may be complaining of distinct challenges. They may report this dull aching or bruising sensation or tenderness when they take off their lens, difficulty with removal. Again, they may see that their eye just becomes red upon lens removal, and you might even see it in clinic when you stain with fluorescein, like an impression ring. And in more significant cases, the patient may actually see a ring around their eye if the lens is too tight and causing this, suction over time. They may have blurred vision that's transient related to the swelling, and discomfort and ultimate lens intolerance, which is something we really don't want our patients to experience. So effects of suction are many and not good. So this can lead to, lens intolerance. They can't wear their lens for as long, or they have to take breaks in between days of wear, redness, neo, which we definitely don't want to see, edema, as well as compromise to their vision. So I'm going to let Dr. Pisano talk about some of the short-term and kind of long-term effects as well.
Thanks, Gloria. So looking at the short-term and the long-term kind of goals of relieving suction, we want to improve the patient's comfort. We want them to have easy removal. I never want the patient to feel anxious when they take their lens out because it's going to feel suctioned. That's always an uneasy feeling for them. But also mitigate any redness that they get as a rebound effect. But more so, our main goal with scleral lens wear is we want the eye to look untouched when we take the lens out. So we want to improve the corneal response when we take it out. That means not seeing any edema and really closely looking at the limbus. So we'll talk about that more with some cases. Long-term wise and relieving suction, we just want to prevent any hypoxic stress to the corneal environment, preventing corneal neovascularization, preventing edema, and overall just improve the patient outcome and their experience with the lens. So when we're looking at how the lens fits on the eye, one thing that's always really important is to look at how the lens appears, the fit, when you first see the patient with the lens on. And sometimes you'll see this upper left picture where the eye looks perfectly quiet. The patient's not complaining of anything. Everything's great. You read all their chief complaint. You're like, oh, this is a great fit. Their eye's white when I walked in. And then you take the lens out. And that's what these bottom two pictures are showing a representation of, is how important it is to make sure you remove the lens on every visit and look at their cornea with the lens out. and doing this pretty immediately after taking the lens out. So we have various tools to reduce suction, and there is an order of operations, if you will, when we do this, of a kind of an order that works the best. So the first, we always want to look at optimizing the haptic. Is it aligned correctly? Is there any areas that we need to loosen to align it more easily with that corneal or that conjunctival and scleral surface? Next, we can increase lens diameter. Increasing the diameter just distributes the weight of the lens more evenly across the broader surface, so it will reduce some suction that way. After those two items, we next can add in SmartChannels and add those to our fit to kind of see if we can mitigate suction. And we'll kind of talk about different cases and how we use those and what number and where to place them in a few minutes. And if adding those three things doesn't help, then we'll move on to a haptic fenestration or an optic fenestration as last resort. So with the BostonSight SCLERAL, there are three unique properties that really aid us in fitting these patients we're trying to reduce suction with. The first is the spline curve technology. This allows us to change parameters independently of one another. So we're not worrying about, oh, if I change one thing, I have to compensate this other thing. That's very helpful when you have a fit that's going very well. You just want to minorly help something. Next, we have various diameters we can use with the BostonSight SCLERAL, and that's what helps with mitigating suction. We can go up in diameter a little bit and kind of incrementally change that. And then lastly, the addition of SmartChannels. So why and when do we use SmartChannels? There's two main categories. The first is to improve the fit over an anatomical or post-surgical obstacle. And then the second reason is to reduce suction, which in many cases, as a secondary benefit, we will improve the tear exchange of the fit as well. So when we look at fitting over obstacles, the main goal is to land over that obstacle as gently as possible to remove any mechanical or kind of chafing of the lens over that obstacle. And we usually will see this in patients that have a pinguecula, a lot of post-surgical irregularities, especially our glaucoma patients with filtering blebs or tube shunts, but also with sutures. And then anything on the conjunctiva that's lumpy or bumpy is kind of an area we can address. And then when we look at using SmartChannels for suction, we're mainly looking at improving that corneal health and looking at the cornea from front to back, looking at their epithelium, their stroma and edema, looking at their endothelium, but also for our patients that are post-transplant. And if they have a high-risk graft, they've had issues with hypoxia in the past. And again, with limbal health. This is a patient that I saw that she came in and she's like, oh, the lens feels fine. And this was from somewhere else. I kind of inherited her. She had no complaints. And this is what it looked like taking it out. So that's why it's so important to look at the limbus and stain it and be very particular with how you document it as well. And then when we look at using the SmartChannel for suction, the biggest thing is the patient will say, oh, this is hard to get out. And my first go-to is I will take the lens out myself and see truly, is this a suction issue? Is this, from their corneal shape? Is it from the lens sagittal depth? Is it from the diameter? Is it from how it's settled? Because we cannot predict how much lenses settle from patient to patient. And if I take it out and it comes out easy, then we know it's a technique issue, like Dr. Chiu mentioned, and we may just need to re-educate them on proper removal techniques. And then when we start to use different modifications with SmartChannels, we definitely have this order, like I said, of operations. So Dr. Chiu, kind of what's your process here when you start to incorporate a SmartChannel?
So for new patients where we're starting, trying to select the right diameter, the toricity, and the contour, generally I will start with the toric fit. And before I utilize some of the more advanced modification methods, I will do my best to get a proper fit by maybe adjusting the diameter. So if it does feel a little bit tight from seeing some compression or the patient's complaining about a feeling of tightness, I may go a little bit bigger, maybe 0.5 millimeter larger in diameter, maybe even 1 millimeter. Then I will try to contour the toricity properly. So you can steepen a particular quadrant, make sure you get the right toricity and a stable fit first. So just because I'm getting a tight fit, I'm not going to throw in a smart channel and say, oh, it's tight, but let's just throw in some channels and that'll fix the issue. No, I'm going to try to fix the toricity and get the best fit possible, and then use the channels to really enhance the fit with situations that you just described, with endothelial dysfunction, in cornea grafts, in corneas that are a little bit weak or require that extra tear and oxygen exchange. So I like to wait until towards the end when I've really hammered down the proper fit before I add in channels. So what do you think?
I agree. I think if you have, a new patient that you're kind of starting from scratch and you can optimize the haptic and the landing and the diameter, that's definitely the way to go. I have had some patients where the fit has to be accelerated for one reason or another. They're leaving, they're moving, or we're only going to be able to see them a couple times because of how long it takes for them to get to the office. And sometimes, depending on that, I may start with smart channels. If a lot of times patients will come in complaining, like, I've had suction lenses in the past, or they're not wearing sclerals because they've dealt with suction in the past. And sometimes that can help them kind of ease into it a little bit, but then still making sure you have all of those goals checked off with the fit at the end.
Love it. Totally agree. And on the flip side, if a patient has been an established wearer for maybe a couple years already, and they're suddenly complaining or just kind of bringing to your attention, sometimes I have some difficulty removing my lens. I may add channels onto their current fit already. And then sometimes you have a patient who maybe has a graft and they've been doing fine in their current scleral lens design. And then you're like, you know what? You're already on using a topical steroid. I'm seeing some changes I don't like in the graft. Then I might add it on later, not necessarily starting from scratch, but adding the channels to an existing fit. And I think that's something you can do as well. So
yeah, exactly. It's so patient independent sometimes based on the complexity of the condition.
Absolutely. So let's talk about how to customize these BostonSight smart channels. So first of all, I think both of us agree that you need to, for the most part, start with a good fit. You want to know that the lens is stable, that you're pretty set on the diameter, the vault, as well as the toricity and contour. So you know that the location of the dot is stable when they place the lens in their eye. Then you need to decide, where am I going to put these channels? You can put between 1 to 4. And you might also think, okay, how deep do I make this channel? So you do have, ability to change the depth of your channel, but typically we recommend going at about 0.15 or 0.2. So that's 150 or 200 microns. The max is really about 0.25, because if you make the channel too deep, it does become quite thin at that point of the lens, and you don't want to make it so thin that it's not supporting the fit, or that it's too weakened in that zone. And lastly, you need to decide the width of that channel. You can make it really thin and deep, like you're really getting like a deep channel through it, or you can make it a more broad and not quite as deep, depending on the effect. If you really want to get, it's kind of like a tunnel, and you want to really make sure you're getting tear exchange or oxygen flow, you can make it thin and deep, or you can make it broad and flat if you just want a little bit of thinning to kind of loosen up that pressure, lessen the pressure in that zone. So you can see here where you're going to enter the number of smart channels. You have to enter in degrees where the channel starts and ends, and as well as the depth. And then there will be a picture as to where those channels will reside when the lens is on the eye. So here in the photos, you can see an example of one channel. You can see one with two across from each other, nasal and temporally, and then even 4. So we'll kind of talk about how you can customize these things as well. This is just a larger image so that you can see how to enter the data in Fit Connect. So if you have one channel, you're starting at 10 degrees, ending at 350. So here the channel is 20 degrees wide, and then the depth is 0.15, which is 150 microns. And you can play around with it. You can change the degrees and kind of see how that impacts where the channel lays over your patient's eye. And then you can change the depth. You can remove it if you decide you don't like that and reset and add a new one up to 4. You also want to make sure you notate the location of the dot, because that does influence how the channels are made in the lab. So let's talk about this. Is there a correct way to design channels? How would you answer that?
I think it depends on the reason you're doing it. So, right, like you said, you're like, if I'm just trying to get, to relieve suction, I'm going to be very intentional with where I put them, the direction, how wide, how deep they are. If I'm trying to do it to get over an obstacle, that's a totally different story of where you're going to put it, how wide they're going to be. And it's so patient independent of what the goal is of putting that smart channel in.
And I completely agree. And also, sometimes you don't exactly know how the channel is going to impact the fit or the comfort or how the patient will like it. So if you think when you are designing one of your lenses that there's a little suction, it's a little tight, just start with something. The consultants are wonderful. You can talk with them, get their knowledge and expertise. Just start with 1 or 2, nasal and temporally. And like we said, generally you want to start at about 150 microns and at least 20 degrees. So that's kind of a good starting point. And then depending on how your patient responds and how their eye looks, you can either make it larger, smaller, or deeper if needed. So there really isn't a correct way. And this is an art form. So there may be a little bit trial and error involved as well.
So like Dr. Chiu said, the dot location is very, very important with smart channels. So it's really paramount that there's some way that you consistently document this. I tend to use this photo on the left, the little reticule at the top, and mark in degrees. Dr. Chiu said she typically uses clock hours. But whichever way you do it, make sure you're consistent and you document it with each visit. I even document it over the course of a full fit. I'll put, okay, last visit was this, visit before was this, because if that dot's moving around, you know that the haptic is not stable. And you'd be surprised, I've been surprised how bad of a guesser I am where the location is. So that's why I'm really, really specific. So sometimes you can take pictures too and send it to consulting and show them like, hey, this is what I'm trying to do with this channel. This is what I'm measuring. Does this look, correct on your end? And I will say when you design over an optical, I'll talk about a case where you definitely want to add more width and kind of bracket around the obstacle, because it definitely is more of a larger area than most of the time we perceive it to be.
So let's go into a little bit more of a review. How do we design the channels? And what do you need to be aware of? So in looking at the design, again, you want to make sure you've kind of decided upon the diameter and the toricity in the different quadrants of your lens. You want to make sure that you have a final stable fit and you know that the dot is ending up in the same place each time the lens is put on. And then this is where you can think, all right, you know what? I think this patient's going to benefit from some smart channels. Let's start adding them. And we talked a bit about, okay, where do you start? It's generally a good practice if you start with 2, nasal and temporally. This kind of is a good placement given how our eyelid blinks and the movement of the lens. And if you need more of an effect, you can add another 1 or 2 more up to 4, and this gives you an additive effect. Again, you want to use about channels with 150 to 200 microns of depth. Try not to go beyond 250, and typically about 20 to 30 degrees wide. So this is an example of what the image might look like in Fit Connect if you're designing for channels. So let's get into some cases here. So this is case A. This is a patient I had, 70-year-old white female. She has dry eyes. She's had RK and has scars in both eyes, so fluctuating vision as well as dry eye and discomfort. I fit her 4 years ago with lenses in both eyes, and she's actually been doing great. She's not getting clouding. She's getting acceptable vision. She's happy with it, good comfort. But she did mention, Dr. Chiu, the only thing I can complain about is sometimes when I go to remove my lens, I feel like I'm pulling a little bit and it's a little bit tight. But other than that, I'm fine when they're on. I don't have any pain on removal. Her eyes aren't red. She just had a little trouble with removal. Although we reviewed proper placement of the plunger location, wet the tip of that small plunger, pull it from the edge, she still, even with that, I still feel kind of a pull, and I don't love it. So I decided to add 2 channels, nasal and temporally, a couple years later in both of her lenses. And what do you know? It helped with that mild suction or this like pop. She feels like kind of like a little pop on removal. Fit and comfort were fine otherwise. So I added these channels to her fit several years later when we decided we needed new lenses. And it was as simple as that. It didn't change the vault. It didn't add to further clouding or debris. And it helped with her slight pop on removal. And here's another case. Dr. Pisano had mentioned kind of fitting those lumps and bumps on irregular shaped scleras. This is a 50-year-old Black female. She was referred to me for fitting. She has some complex history with kidney disease, some unknown autoimmune disorder where she's uncomfortable, just physically, ocular. She's just not really happy overall. She has pellucid in both eyes, as you can see with the corneal tomography images, dry eye, and also pretty fleshy elevated pinguecula nasally in both eyes. Now, she had been seen previously with other providers and told me, I cannot wear any of those lenses. They're so painful. They feel tight. I feel suction, redness, pain. It's dramatic. She's very sensitive. And I even thought, oh my gosh, I don't know if I can help her. It sounds like a lot's going on. I wonder if she's even a good candidate for scleral lenses. But given her cornea, as you can see here, glasses don't work. She just can't function without lenses like this. She can't tolerate RGP because they ride so low and decenter. So I thought, okay, I'm going to do the best, possible design I can do. But I want you to be aware, I'm not a magician. I will do what I can. And I think that's a good reminder for all of us as practitioners. We shouldn't promise that we can fix everything. We can do our best, but we also need to be realistic, right? So she also did mention that most of the lenses that she tried in the past were pretty small diameter. So right from the start, I went large and loose. I started with an 18 millimeter diameter in a toric fit. I used an Optum Extra material. With this design, she already complained about discomfort after 1 hour, soreness, clouding, that the lenses felt suctioned, and she could only wear them an hour, despite them looking not too bad. So I didn't want to jump to any advanced techniques, so this is just a toric design. In the second set, I did look at the fit, made some slight adjustments to optimize the toricity, and I decided, okay, let's just add a smart channel to one eye over that pinguecula. Let's see what that effect is. So with the channel only on the left eye, she reported discomfort after 2 hours, some clouding still tight, and more redness in the right eye than the left, despite the modifications. So you can see here on the left eye, I added a channel, 30 degrees in width and depth of 0.15. So pretty standard for starting over the pinguecula nasally. And I had to go to another set. So in the third set, I added now a channel nasally in both eyes. I also contoured the toricity better, tried to loosen it, and I also tried to change the material because maybe that was impacting her comfort. Overall, she said it was better in both eyes, but still not quite perfect. So in the end, I was able to get quite a good fit in her left eye with just one wide channel nasally. In the right eye, I did have to switch lens designs completely, which helped her overall comfort. And, you know, as providers, we need to know when to utilize certain techniques and certain modifications. So in this case, I did have to switch the design in the right eye, but in the left eye, she did very, very well. And this led to good functionality for the patient. She was finally satisfied. She would come in. This is one of those patients where you would have those heart-to-heart discussions every time. You feel like you're just listening and trying to be understanding, but she could finally wear them for 7 hours. And this was a huge huge progress for her, having only been able to wear lenses in the past for maybe an hour with significant pain, redness. So in the end, she was in an alternative design in the right eye. And this is a picture of her left lens, which with the nasal channel, the front and back views, you can see the 2 dots, and you can see what that channel looks like on the patient's lens. Now I'm going to share another very interesting case here. Case C, patient of a monocular graft. This is a 65-year-old male. He's monocular. He wears a prosthetic lens in his left eye already. He had an injury which led to an infection and blindness in his left eye about 13 years ago. In his right eye, he had a penetrating keratoplasty due to keratoconus in the 80s, so almost 40 years ago. And he has been wearing a scleral lens in his right eye now since 2009. So that's about 14 years. You can see from this profile image taken from the Pentacam, the graft is very, very highly vaulted. So not surprisingly, we had to create a very highly vaulted lens. And because there were some limitations in how high the lens could be designed and vaulted, we decided to use a fenestration right from the start in the optic, because this was a 39-year-old graft and he was monocular. So we really, wanted to throw in all the bells and whistles here. He was refit at BostonSight and he had 2 fenestrations and 4 channels. This was an extremely high vault. I'm going to show some pictures in a minute. There was still slight feather touch on the cornea and a controlled bubble inferior temporally over the graft, because we wanted to make sure that enough oxygen was getting to the graft. In the end, as we've stressed, the cornea health is very, very important. We need to make sure we're not going to lead to graft rejection or failure, particularly in this monocular patient whose graft is almost 40 years old. The VA was cut off a little bit, but he achieves 20/50 vision in his only right eye. And here's an images provided by Dr. Alan Kwok from BostonSight. And you can see how we developed fenestrations to create this controlled bubble. And at first, when my tech saw this patient, she wrote big bubble in his lens. And then I realized when I saw him, we actually want that bubble to be there. So when you're dealing with more challenging cases where you actually want oxygen to get to the cornea, it might be okay to see a bubble like this. And especially if we're controlling the location so it's out of the line of sight. And if you see this area, you might be thinking, oh my gosh, what are you doing? There's touch there. Yes, I understand there is touch there. That is why we put the fenestrations. There's a bubble, and you can see here that there's 4 channels. All of them are 20 degrees in width and 200 microns in depth, as you can see here. And most importantly, as we've stressed already, when you take the lens off, You need to make sure the cornea looks okay. You're not inducing an abrasion or staining on that cornea or graft. You see some irregularity related to the irregular eye shape and graft, but in that area where there was feather touch, we're not seeing staining. So we know that despite the fit not looking the most beautiful or pretty, he's getting good functional vision. He's comfortable. He's not complaining. And this is a very, very highly vaulted lens. For any of you who look at your lens on the plunger, most of them don't rise this high. Most of them are not the same thickness as your thumb. You can see here that this is a pretty extremely designed vault. And you can see the channels here on the side. And then there's also those two fenestrations in the optic area that control the location of the bubble. So that's not a typical fit, but I did want to share that because here we were able to utilize fenestrations, channels, as well as the importance of understanding that even with highly complex ocular cases and in monocular patients with 40-year-old grafts, we can still achieve success if we're monitoring closely and really just using all the tools we have available, including these smart channels, to make sure that that cornea graft is staying healthy. So I am going to turn it over to Dr. Pisano to talk about some more of her cases.
All right, thanks, Gloria. So the next case we're going to talk about involves a 53-year-old Caucasian female. She was sent for a contact lens evaluation with a history of advanced glaucoma and corneal ectasia. She had recently gone under a combo procedure for cataract surgery and a tube shunt. And she comes in, you can see this is her corneal topography here. She's 2100 in her glasses, not surprising given the shape of her cornea. I tried a GP first because if we can avoid touching that area with the tube shunt, that's the best, but too unstable given the shape of this cornea. And with the scleral lens, she was 20/20. So Gloria, if you advance one click, yep, you can see her tube here. So she had this pretty prominent anterior tube. And then if you go to the next slide, we'll start to look at the placement of the channel. So this was one where it was really important that I documented exactly the location. And you can see this upper channel at the top of the screen, channel 1. That is the one that's going to go over her tube. And then the channel inferior there, I kind of placed it to kind of balance the lens and from a suction standpoint, since the upper channel was there. And then as we follow this patient on the next slide, you can see we use anterior segment OCT in our office to measure the thickness of that conjunctival tissue that's kind of sandwiched between the lens and the tube. And this patient's worn this lens design with the Smart Channel for almost 3 years with no adverse events, always taking the lens off, taking pictures, looking at the tube, making sure that area is not becoming excavated or exposed, checking her pressure, and regular follow-ups with her glaucoma specialist. So just a good use of the Smart Channel with the conjunctival obstacle. This next case is a 34-year-old male. He had transplant secondary to keratoconus, and he requires long wear time due to his work schedule. This was non-negotiable. He said, I'm going to have them in 20 hours, so they cannot be tight. He said, I've had tight suction lenses in the past. And you know, with these patients, they can't take a lens holiday. They can't wear their glasses. We have to design these in a way to make these work for their demands that they need for their everyday life. So we utilized our endothelial cell count machine to kind of monitor his endothelial health. And he has had some issues with graft rejection in the past. So we know we want to be very specific with how we're fitting him. So in his lens design, the lenses here, you can see this is the lens on his eye. He comes in after a shift and the lens is on for like 16 hours. So this is a good testament of how well these are working. And here he has 4 channels in his lens. And you can see I kind of placed them equidistant from each other and using the 0.2 depth and a little bit wider just based on the risk with his graft. And he's 20/20, no issues with suction. He always comes in and the chief complaint, it says best lenses ever, because he's always so happy that he can leave them in for his full work schedule and he's not in pain or struggling to wear them during his workday. So this next case, we're going to talk about the additive effect of channels, because if we add them kind of sequentially, we know we will get more of a benefit. This was a patient, again, keratoconus with a PK. And this is a good example, Gloria, like you said, of kind of starting from an established fit. She came in for her typical follow-up and said, you know, my right lens is a lot easier to get out than my left. And it's just kind of frustrating. I wet the plunger, I take it out properly. And again, she's great vision improvement with her lenses, 20/20. So if we look at the lens fit in the right, that's the easier one. So on the next slide here, you can see she already has 4 channels in this fit from her previous fit that we did a year prior. No issues with removal, really easy tear exchange under the lens, but no issues with debris or fogging. So she's doing really well in this eye. So we're not changing anything there. If we go to her left eye, you can see she has 2 channels here. Channel 2 was for a pinguecula, and you can see a little bit less tear exchange going underneath. So kind of giving us a clue that it's a little bit differently landing and fitting than the other eye. So the plan is just add 2 additional SmartChannels, just add them to that superior and that inferior quadrant to give her that 4-channel design. And immediately when she got that lens, she's like, it's so much easier to get out. I have no popping sound. I'm not nervous when I go to take it out. So just a great example of adding channels over time can be very helpful. And then my last case here, this is a patient that was a 53-year-old graft versus host patient with significant ocular symptoms. He came into the Advanced Specialty Contact Lens Clinic wearing bandaged contact lenses, doing drops every 15 minutes, and everything he could pretty much do to mitigate his ocular symptoms. But his eyes were so uncomfortable, he was getting ready to quit his job. So he's like, I have to do something. And these patients, they're really hard when you first meet them because they're frustrated. They can't see, they can't keep their eyes open. They're hard to take pictures of. So we got his baseline pictures here. You can just see a lot of staining on his corneal surface. So going to the next slide, we fit him with diagnostic BostonSight SCLERAL lenses. This is the dispense, and GVHD eyes are tough because you're fitting them at a point that they're inflamed. So you're starting the fit from an inflamed point and you're hoping to go the opposite direction. But he was 20/20 in his lenses, so about a 3-row improvement. So he successfully did application removal. We let him leave with the lenses. And then on the next slide, you can see his initial follow-up. So in this right eye, if you can go back one, Gloria. Perfect. So in his right eye, this is the same lens from the dispense, but his eye just looks a lot less inflamed, much more quiet, no staining when we take it out. So excellent improvement from that standpoint. And then if you go to the next slide, we can see his left eye, pretty similar. Excellent fit, no staining when we take it out. And then when I was talking to him further, he said, you know, this is great, but it's hard to take these out. And I'm nervous to take them out. I don't want to feel that popping sensation. So on the next slide, I kind of talked him through this and I took the lenses out for him and he was able to wear them 16 hours, but he came in at the 8-hour mark and I took the lenses out and I did feel that popping sound. So I just added the nasal temporal SmartChannels in both eyes, changed nothing else with the fit, did the 20-degree depth. And then that was all we needed. He was super happy otherwise. And then if you go to the next slide, Gloria. So this is a zoomed in picture of the channels on his eye after multiple hours with both white light and then the blue light. And you can kind of see exactly where they're landing and how it's landing over that conjunctival tissue. And then this was his follow-up. He's been wearing lenses for multiple years and he's happy. These GVHD people are so immensely grateful when they can get lenses that work really well. And in his case, the SmartChannel was just the additive kind of bonus we needed to make him feel perfectly comfortable with his lenses.
Thank you so much for sharing those really amazing and life-changing cases there. You know, sometimes we fit scleral lenses and we think, oh, you know, the lens itself, that's all we needed. But sometimes we have to go the extra mile and think a little bit more critically about how we can make that fit even better to give our patients the best experience, not only comfort-wise, vision-wise, but also considering their ocular health. So in the last couple of minutes here, I would like to share a publication that came out of BostonSight by Drs. Jennifer Liao, Bita Asghari, and Dr. Karen Carrasquillo. And they published this paper in the American Journal of Ophthalmology case reports. And in this paper, they discussed 2 cases where there was documented regression of corneal neovascularization and clearing of corneal opacification in patients with SJS and toxic epidermal necrolysis undergoing PROS treatment. So 4 eyes were included of these 2 patients. And in both of these cases, regression of the neo and clearing of that scarring was observed. 4 eyes demonstrated improvement in visual acuity. And with PROS treatment, both patients ultimately were able to discontinue all their prescribed topical therapies. Some of these included topical steroids. One of them was on concurrent topical immunomodulators and other therapies as well. But with the PROS treatment, as well as some special modifications here, so on topic, when they were retrospectively reviewing these 2 cases, the doctors realized that all 4 eyes had also been managed with PROS devices that had back surface channeled haptics. So they didn't necessarily expect this, but in, doing this case report, they realized that in both of these cases that had these positive changes in the corneal presentation, that channels had been utilized. So you can see here some images. They used these back surface channels to optimize the fit and enhance comfort by increasing the tear exchange and decreasing suction on the eye that allowed for better wear time. Now, it's possible that these added channels allowed for the oxygenated tears to get to the lens reservoir. And we've seen that just in the photos that you just shared, Stephanie, that you see where the fluorescein is able to enter into the lens or into that fluid reservoir. And the reduction of the suction forces may have actually contributed to further improvements in the ocular surface. So here are some images that demonstrate one of the patients. And you can see at baseline, you cannot see the shape of the pupil. You can't really see the iris detail, the iris color. All you can see is scarring and neovascularization. At 5 months, you can just slightly appreciate the location of the pupil. At 10 months, you're seeing the pupil more clearly as well as the iris detail, and you can see clearing of the central scarring. And then at 17 months, you're definitely seeing a dramatic change in where the blood vessels are. You see regression of these deep red, vessels peripherally, and you're able to see the detail of the iris and the pupil contour much more clearly. So yes, you see this progression here. Let me just go back a little bit. So I had asked Dr. Carrasquillo, can you share some details? So in one of the patients, they utilized 2 channels, nasal and temporally, pretty standard with what we've discussed at about 30 degrees and 0.15 microns. And in the second patient who had more significant corneal opacification and neo and a more severe case of Stevens-Johnson, they used 4 channels. And 2 of them had depths of 150 and 2 had a little bit deeper, about 200. So you can also mix and match the location, the kind of how many degrees the channel spans, as well as the depth within a single lens itself. And many of the examples that you shared, Stephanie, they weren't just 2 channels of the same side exactly across from each other, although that's okay. I've done that and it's still helped. But if you see obstacles in certain locations, or if you're noticing rotation of the lens where you think you might need to be a little bit more precise on where the channel spans, that's totally fine. And you do have the ability to customize the size and shape of that channel. So I thought this publication was really neat, really special to show how these modifications, may have really contributed to the success in what we're seeing in the cornea tissue and vision over time, and also reducing the need for topical steroids. I mean, that's huge, especially in young patients who, if they're using topical steroids, may be at risk for developing glaucoma and PSC cataracts and needing, earlier surgery. Anything we can do to delay surgery or the need for further surgical intervention in SJS patients is really huge. And so if you have more questions or want to learn more about how to use SmartChannel technology, there was a great webinar created by Dr. Bita Asghari and Alan Kwok that you can access at the BostonSight Practitioner Learning Center. You can find it on BostonSightSCLERAL.org. And you can also subscribe to their YouTube channel at BostonSight. And they have this great webinar titled Channeling Scleral Lens Complications. And they provide a crash course in the use of SmartChannel technology. So I know we covered the basics of how to do that over this past hour and shared some of our clinical experiences. But if you're looking for more, you can find more at BostonSightSCLERAL.org. So Stephanie and I want to thank you for your attention over these past 50 minutes. And, we're really honored and we feel very, blessed to be able to do what we're doing and helping these patients who require scleral lenses. And not only that, but that we have the ability to use these BostonSight SmartChannels when we feel appropriate to enhance our fitting outcomes. So I am going to invite our moderator, Laura. Thank you for being here and for helping us plan this webinar, by the way. And I'm going to let you take over our question and answer session. We have about 8 minutes left.
Yes, thank you. And excellent presentation. Learned so much about this and great case study. Looking at the questions that have come through, there are several questions regarding fogging, midday fogging. Do you, and you guys can both share your experience with this. Do you ever see a lot of midday fogging or debris entering into the tear reservoir because of the channels? And if so, how do you fix that?
Stephanie, you want to take that?
Sure. So I think the first thing is, from my clinical experience, I put channels in a lot of people, and I don't really see midday fogging, especially when I'm using it for suction and I'm putting them nasal and temporal. Like Gloria talked about, that blink action superior inferior with our lid, as long as they're nasal and temporal, I don't really see an issue. It comes into play if the lens rotates and you're not paying attention to the dot and the channels rotate off the axis you want them to be at. So that's really important. And I also utilize kind of like a pseudo Seidel sign. When they're behind the slit lamp, I'll have the patient look down, put fluorescein just posterior to the lens edge, and look for liftoff somewhere in the haptic, because that's usually the culprit. It's not usually the SmartChannel. Or sometimes when patients come in with debris, I'll see the dot in a weird position, but I'm like, hey, the dot's always, in this position when you come in. Why is it down there today? It's at the bottom. They're like, oh, I put it in incorrectly. So you really have to pay attention to their insertion, if the dot's been stable, but also, is there a haptic issue? I more so see debris with haptic. What do you think, Gloria?
I agree. I don't really have many patients who have the SmartChannels complaining about more debris or clouding. I mean, you can have issues with midday fogging with or without channels. So it's really, as you just said, really the profile of the lens itself that could be the culprit to the clouding. So if, however, you have a lens that's fit without channels and then you just added the channels and you're seeing clouding, some techniques you could do are maybe making it not as deep. So maybe if you did 200 depth, you might decrease it a bit to 150 or even 100. And maybe you could decrease the width of it a bit. So maybe if it was 30, you could bring it down to 15 or 20 degrees. But most of the time, I'm not getting complaints of extra midday fogging just with the addition of channels. And I think it's also important to know, and you can even see it in this picture here, the edge of the channel and the area where the lens is thinned on the back of the lens doesn't actually extend to the edge of the lens. So where the edge of the lens lands on the sclera is generally the same, but it does allow, when the lens does blink, when it moves, you are getting a thinned zone there. So that's how you're getting the effect, but it's not necessarily creating like a big gap where, debris can cause, it leads to intrusion.
Very good. Yeah. Yeah, we've seen in our clinical research that, if you stick to kind of where we recommend to the width and the depth of the channels, usually we don't see we don't hear a lot of complaints, and you don't see that. And great. Let's see. I think we have time for just one more question. It has to do with fenestration. When would you consider going to a fenestration with the SmartChannel? And where do you place that? Haptic or in the optic zone? And if you do place it in the optic zone, does that change your fit?
I'll take this one. So I will tell you that I try to create the most basic fit, like the majority of the time, if I can. So I'm not going to, just because I can, add SmartChannels and fenestrations and do all these crazy things just because I can. I really am doing it on a case-by-case basis if the patient needs it. And so I will utilize fenestrations if needed, but I will say I don't use them very often. However, if you're having a patient where you really need more tear exchange, you're really concerned about, transient edema or the graft, or it's a Fuchs patient, you can put a fenestration in the haptic where the channel is, and that kind of just breaks the suction further. So you're loosening it beyond just thinning the back. You're actually allowing for tears to exchange. So you're getting a greater effect of breaking the suction there. And that really doesn't impact the vault or the fit as much, but you are getting more of a break in that suction. Now, in the case that I shared, there were 2 fenestrations within the optic zone that actually created a bubble. And when you put fenestrations in the optic area, it does change the fit much more. And you do have to be aware of the vault, because if you fit too high, you're going to get really big bubbles. That's going to lead to discomfort and compromised vision. So when you do fenestrations, you usually have to control them, do them peripherally in maybe areas where there's just naturally more clearance in an ectatic eye or in a graft. Do it, where you're seeing more clearance, and try to fit flatter elsewhere. That's why you saw a little bit of feather touch in that design. And then the bubble stayed out of the line of sight to allow for the oxygen exchange in that 40-year-old graft, yet he was still seeing 20/50 and still was able to maintain good health. So doing fenestrations, the more centrally you get, the more complicated it can be. And I don't recommend going that route unless you really have to and you've tried everything else to optimize the fit, toricity-wise, material-wise, thickness-wise, getting the most contoured fit possible before you add fenestrations, whether it's in the haptic or the optic. What do you think, Stephanie?
I totally agree. Fenestrations are challenging. They are such an art, and they can make the fit very complicated. So like you said, like really stepwise approach, doing all you can to everything else. And then, if you have to, you've already put the max channels in, do a haptic fenestration. And that's where the consultants can be very helpful, because you can really get their expertise of what you're trying to do and where you're trying to put it. especially so it's repeatable if you have to reorder a lens later. But yeah, fenestrations are tricky. So you want to do what you can with the tools you have, but be intentional with what you're doing.
Right.
I know we're out of time, Laura, but I did also want to comment on pinguecula because they're very common. If you have patients with pinguecula, I think you should first try to play with the toricity and the size of your lens first. I find that with even fleshy pinguecula, if you go really big and try to vault it and do a flatter contour over the pinguecula, that in itself may be helpful enough. And then if that isn't, and you're still getting a lot of injection on the pinguecula on removal or impingement over the pinguecula, that's when you would add the SmartChannel to cover the entire pinguecula area from kind of going beyond the edge of it and really measuring that, and maybe going a little bit deeper for pinguecula. I did see that question. I wanted to make sure we addressed it.
Yeah. And more of the pinguecula, the conjunctival obstacles are explained in that webinar that you referred to in this. So I do encourage everybody to view that because it does show you how to measure over those pinguecula and how to manage the fit over those. So yeah, so we are out of time. So all of the questions that we didn't get to within the Q&A session from all of our attendees, we will address those in a follow-up email. So be sure to be on the lookout for that along with the link to today's webinar. We want to extend our full gratitude for Dr. Chiu and Dr. Pisano to present tonight and take time from their busy schedules. We appreciate you, and we hope that we can see each other again soon. So bye, everybody, and have a great night.